Good afternoon. Thank you very much for the opportunity. My name is Clarissa Gerhardt, and I am part of the Pediatric Allergy and Immunology Division of the University of São Paulo. Today, I'm here to present the research safety of yellow fever vaccine administration in confirmed egg-allergic patients. To start, a brief story for better context. The year was 2016. There was an outbreak of yellow fever in Brazil, with a large increase in the number of cases between 2017 and early 2018. Over 1,000 cases were confirmed, with nearly 500 deaths. Some locations, such as our region, São Paulo, was not considered an endemic area of the disease at first, and the population was not fully vaccinated. As we know, the vaccine is the most effective way to prevent this disease. This outbreak forced the Brazilian Ministry of Health to indicate the vaccination of the entire population. Then we had to vaccinate the whole population quickly. But during the manufacturing process of the vaccine, the live attenuated virus is inoculated inside an embryonated chicken egg. And this may pose as a risk for egg-allergic patients. Although the allergenicity of the ovoalbumin can be reduced by an increase in temperature, this stage is not included in the vaccine's manufacturing process. This process of using chicken eggs allows the detection of the ovoalbumin in the vaccine. The vaccine was not indicated by our Brazilian Ministry of Health for egg-allergic patients. Besides that, there was a lack of published studies proving the safety of the yellow fever vaccine administration in confirmed egg-allergic patients, especially in those with severe manifestations. So, how could we safely vaccinate them? That's why we, from the Pediatric Allergy and Immunology Division of the University of São Paulo, decided to evaluate the safety of the yellow fever vaccine administration in these confirmed egg-allergic patients. There is a vaccine desensitization protocol. However, it had never been tested if the patients at the time they were receiving the vaccine were already tolerant or not to the egg protein. Our study included egg-allergic patients confirmed by oral food challenge near the vaccination date, or patients with an anaphylactic reaction to egg protein within 6 months before the vaccination date, or patients with a reported reaction to egg associated with a positive egg-specific IgE within 2 months before the vaccination date. And we excluded patients with confirmed tolerance to egg protein after the oral food challenge, and who had other contraindications of the yellow fever vaccine administration, like people with immunodeficiency or undergoing chemotherapy. The oral food challenge to confirm egg allergy was conducted in 2 phases. First, we gave 10% of boiled egg containing the protein ovomucoid. We waited 15 minutes and later gave 90% of the boiled egg. We waited 2 hours, and if there was no objective mediated IgE reaction, we proceeded to the second step. In the second step, we gave 10% of a 5-gram portion with of a freeze-dried albumin powder corresponding to 1 raw egg. We waited 15 minutes and then gave 90% of the portion. We observed for 2 hours. In patients who showed any objective-mediated IgE reaction, we stopped the test immediately and considered it positive. Now about the vaccine skin tests. First, we did a skin prick test with the vaccine without any dilution. If the skin prick test was positive, we desensitized it. If the skin prick test was negative, we would do the intradermal test with the yellow fever vaccine at a 1/100 dilution. If the intradermal test was negative too, we did a full dose of the vaccine. If the intradermal test was positive, we desensitized it. The desensitization consisted of 5 steps. First, we applied 0.05 milliliters of the vaccine diluted at 1/10. Then we did 0.05 milliliters of undiluted vaccine, then 0.1 milliliters, 0.15, and 0.2 milliliters, always within a 15 minutes interval between them. If any reaction happened during the process, we medicated them and proceeded it. We observed the patients for 1 hour after the end of the desensitization. Among 100 patients with a presumed history of egg allergy, 58 had a confirmed diagnosis, 36 male and 22 female, with a median age at the time of diagnosis of 2.3 years old. Of the 58 patients, 42 were confirmed through oral food challenge. 9 had a history of recent anaphylaxis within the previous 6 months. And 7 met the criterion for an egg reaction associated with a positive specific IgE within the previous 2 months. All the patients included in the study, 58 in the total, presented a negative skin prick test and was performed the intradermal test. Only 10 presented a positive intradermal test. There was statistical significance. So we did 10 desensitizations. 6 of them showed hypersensitivity reactions, such as hives and mild reaction during the desensitization. The other 48 patients that presented a negative intradermal test received a full dose of the vaccine without any reaction. About the oral food challenge results. 19 patients reacted to the boiled eggs. 5 presented anaphylaxis, 6 presented hives, 3 presented hives with angioedema, 3 presented vomiting, and 2 angioedema. 23 patients reacted to raw eggs. 10 presented anaphylaxis, 10 had hives, 2 presented vomiting, and 1 only angioedema. 20 of 24 anaphylactic patients received the vaccine without any hypersensitivity reaction. The other 4 anaphylactic patients were desensitized and received a full dose of the vaccine. And 2 patients that reacted during the desensitization were not anaphylactic to the egg protein. This study showed a discrepancy between reported story and confirmed egg allergy, since 58% had a confirmed diagnosis. Thus, studies based only in allergic reaction told by the patient or positive specific IgE may not be reliable. Another point, is the skin prick test really necessary? According to our study, we concluded that it's not, because all the tests were negative. The intradermal test was what differentiates the risk of having a reaction. All the hypersensitivity reactions occurred only in patients with a positive intradermal test. The intradermal test was a good test for screening. In conclusion, it is possible to vaccinate egg-allergic patients with a safe protocol, even in those with proven severe reactions. The intradermal test was a better screening for the vaccine reaction. And always remember that the vaccine should be administered in appropriate setting to treat possible serious allergic reactions. And this is my email. If you have any question, I have only a few minutes. Thank you very much.
Thank you very much. Is there any question? So we start with one question.